Now we have the floor open for your questions. So we have a couple. We'll start first for a question to Dr. Khalid. Uh, what is the sensitivity of bold FMRI in relation to the seizure time and the time frame for that?
Well, so yeah, but overall sensitivity of MRI, of functional MRI is that depends on the way you define sensitivity and what's your gold standard. But let me say that the overall impression about fMRI is accurate, and it's a reliable technique that we can use for functional localization. The only problem that we get is some sort of technical optimization that requires further, requires a learning curve and a practice curve. So whenever you establish a new service, this is exactly what we did in Ibn Sina Hospital. We started our new service for functional MRI in like almost 3 years ago, and now we're doing good. But I mean, it just takes time to establish all the parameters and all the team to be well trained and to know how to overcome the obstacles and the technical optimization problems that we get. But the part of the question that is related to the epilepsy, epileptogenic focus, yes. So the answer is yes. There's a phenomena that we call neurovascular uncoupling, that sometimes it occurs with epileptogenic focus, and also it's maybe more common with tumors. There's no over 100% overall agreement on the significance of this phenomena, but there is some sort of this is something that we should keep in mind when we do the post processing. The good news is that we can correct for that, but my personal experience is, again, is that it's reliable and promising, and there's no major problem if you are doing if you perform a technique of bold fMRI in a patient who has epilepsy in the during that time, unless you have some sort of related to the cooperative to the behavior of the patient, or to the motion inside the scanner. So this is something else, and of course will affect the quality of any MRI study.
Thank you. And the same relation about the DTI images, how frequently are you doing those in the day-to-day work? Do you do them in selected cases or just in research?
Um, so yeah, so the question is kind of complex to me, but the answer no, we don't do this for research. We do this for clinical practice, but again for selected cases. So it has some. There must be some sort of we have to find an indication from the neurology perspective. We have some indications, but they're not as many as the neurosurgical perspective. Of course, for pre-surgical planning or pre-surgical evaluation of tumors, DTI is really important, and we should do this with every case. Let me also add one thing, that the best thing about DTI is that it's a non-invasive technique, and it doesn't require any training to the patient, and it takes only 5 to 6 minutes to acquire the whole sequence. So it's an easy thing to be included in any MR protocol if you have time and you have the software and the hardware equipment required.
So are we doing them routinely at Ibn Sina Hospital now for our neurosurgical cases?
Yes, almost yes for tumor cases. Almost yes for tumor cases, especially if the tumor is close to an eloquent fibers. There's some logistics related to the when the patient is admitted to the hospital, when the surgery is planned to be. Sometimes the patient is admitted today and they plan to do the surgery tomorrow, so we don't have enough time, and especially that some patients come from outside hospitals with preoperative MRI already done, so we don't have any chance or any opportunity to add more. But if we have the time frame, if the lesion is close to an eloquent area, an eloquent fibers in the brain, so the answer is yes, we can do this, and we do this in Ibn Sina more frequently now.
Okay. And next question to Dr. Lamia. For a patient who has a clinical picture of myelitis, could they have a normal spine MRI? Like a negative MRI with abnormal clinically?
Yeah, so one possibility is having a normal spine MRI actually, and Unfortunately, this happens a lot, especially in inflammatory conditions. You might have been imaging too early in the disease course. If you follow up, you might see some changes later on. Another possibility is it depends on the resolution of the scanner. And so more and more now we're seeing people who are doing, there's now availability of open MRIs with lower resolutions. And so unfortunately, we're seeing a lot of patients, going or doing their MRIs in these centers. And so you might have a false negative image. And so, yes, initially you might have a normal scan. And so we all look at the overall picture. And does this patient, if he's not improving, if his symptoms are getting worse, then he definitely needs a follow-up just to document if there's any progression of his disease. Sometimes we want to be hopeful that findings are specific when it comes to myelopathy. And I think my colleague, Dr. Tariq, in his talk talked about all these fancy signs that we might see, the pancake sign and the trident sign. But unfortunately, these are very rare to be seen, even in association with pathologies. And so most of the time, not most of the time, but sometimes you might find that the scan is normal. Sometimes you might find non-specific signs or non-specific signal abnormalities. And if you're lucky, then you will have the classic appearance of the myelopathy on imaging.
The other question also regarding MRI imaging in the multiple sclerosis population, where we image them on an annual basis. Do we do it with GAD on an annual basis? With the recent, some people are questioning the safety of GAD that may remain in the brain for a while.
So this is a very good question, and this is actually our routine protocol includes gadolinium, but we don't have to give it to every patient. There are patients, for example, who are more chronic and who have been stable for a while, and so their follow-up usually does not require gadolinium. The latest about the safety of gadolinium is that it actually deposits in the body, including in the brain, but the safety, it's still considered safe, and there is no question about the safety. It's just that we don't know what's the significance of this deposition yet. And so when it comes to safety, gadolinium is definitely safe, but as to the recent evidence that we have, and we still don't know, but we still don't know what this deposition indicates actually, or what is the significance of it. And to go back to your question, no, we don't have to give it to every single patient. If the patient is stable and over a period of time, and he has his annual follow-up with no new lesions, then you can do a non-contrast study for it.
And I think the final question is back to Dr. Khalid for MRI CSF flow studies. How sensitive or accurate they are in the establishing the diagnosis of normal pressure hydrocephalus, and can we rely on them clinically?
Yeah, let me say there are two aspects of CSF flow studies. The qualitative aspect, where you do some sort of analysis of the pattern of flow, and there's a quantitative aspect where you can measure some figures such as the stroke volume or the flow velocity and things like that. So for the first part, I would say yes, it will give you reliable information. I don't have a specific figure for sensitivity, specificity related to normal pressure hydrocephalus. I have to go and look up this in the literature. But overall, so it can be included in your protocol. It will help give you some information about the flow, along with the structural changes that you have in these patients in clinical data. So overall, you can get some sort of an impression. But for the quantitative part, this is the part that I know that there's a real problem, because there's no optimization way of the methods that we use. And if you do any comparison between different scanners and different at different hospitals, you will get a wide variation in the figures. So that's why we can't rely on the numbers, but we can rely on the pattern of flow, kind of. Yeah.
Thank you so much. And at the end, I would like to thank Dr. Khalid again and Dr. Alamia for their excellent presentations. And thank you all for being with us in this session. And I'll give the mic back to Dr. Jassim Al-Hashir for his final thoughts.
Thank you very much, Dr. Abdulaziz.